Hello, my name is Eric Simon, and I am a third-year medical student at the Medical College of Wisconsin. Today, I will be discussing how to achieve regional anesthesia of the lower extremity in an emergency setting. First, I will discuss some background information, and then there will be two short video clips demonstrating the techniques. A field limb amputation is a rare but potentially life-saving procedure that can be done as a last resort for a patient with an entrapped extremity, often as a result of a natural or man-made disaster. Research indicates that the incidence of this extraordinary procedure is lacking, although current evidence suggests that it is severely underreported. In recent history, there have been a number of events in which field limb amputations were required and performed. These events range from natural disasters, including the 2010 earthquake in Haiti and the 2005 earthquake in North Pakistan, to local events, such as the one in 2005 on a construction site in Green Bay, Wisconsin. Due to the lack of training, suggestions to establish amputation teams and protocols have been made as far back as 1979. However, evidence of such teams is still largely non-existent. A study performed in 1996 quantified this lack of training. Emergency medical service directors from the largest 200 metropolitan areas in North America were surveyed, and 96% of those that responded reported no limb amputation training in their EMS agencies. The Medical College of Wisconsin has previously made instructional videos for performing field limb amputations. However, information and instruction regarding the administration of anesthesia is lacking. This video is meant to be used as a supplement to those created by the Medical College of Wisconsin Department of Emergency Medicine. There are multiple ways to achieve anesthesia of the lower extremity. The example that I will discuss and demonstrate here is a combination of the lumbar plexus block and the sciatic nerve block. The lumbar plexus consists of a group of 6 nerves, spinal nerves T12 through L5, that supply the lower abdomen and upper leg. The peripheral branches of the lumbar plexus are the iliohypogastric nerve, the ilioinguinal nerve, the genitofemoral nerve, the lateral femoral cutaneous nerve, the femoral nerve, and the obturator nerve. The lumbar plexus forms within the body of the psoas muscle. Now, I will briefly discuss the different landmarks and lines that are used to perform the lumbar plexus block. The first line drawn is from the top of the posterior iliac crest down to the midline. In most adults, this line is located over the top of the L4 transverse process. Next, a line is drawn superiorly from the posterior superior iliac spine, parallel to the midline. In most adults, this line is located 5 centimeters lateral to the midline. The intersection of these two lines is the point of needle insertion. Now to switch to the sciatic nerve. The sciatic nerve arises from the spinal nerves of L4 through S3. The sciatic nerve leaves the pelvis through the greater sciatic foramen and travels under the gluteus maximus muscle and down the posterior thigh. The sciatic nerve divides into the tibial and common perineal nerves, which usually do not separate until the mid-thigh. However, separation as proximal as the pelvis occurs in 12% of patients. Now, I will briefly discuss the different landmarks and lines that are used to perform the sciatic nerve block. The first line, indicated by the number 1 in the picture, is drawn from the greater trochanter of the femur to the posterior superior iliac spine. A second line is then drawn from the greater trochanter of the femur to the patient's sacral hiatus. A third line is drawn perpendicular to the first line at its midpoint. The intersection of this third line and the second line represents the point of needle insertion. Finally, a fourth line is drawn along the groove formed by the medial edge of the gluteus maximus muscle and the long head of the biceps femoris muscle. This line represents the course of the sciatic nerve as it travels towards the lower leg. The triangle formed by the second, third, and fourth lines further defines the point of initial needle insertion, and subsequent adjustments of the needle should be within this triangle. There are many different local anesthetics that can be used to perform a nerve block. It is too complex of a topic to fully discuss here, But when picking an anesthetic, it is important to keep the following points in mind: onset of action, duration of action, anticipated degree of pain, and the toxicity of the agent. The onset and duration will vary depending on the nerve block, and listed here are averages of the various peripheral nerve blocks. Epinephrine causes vasoconstriction of the surrounding blood vessels, which decreases the absorption into the surrounding vasculature, allowing the block to work for longer. A good first choice for any peripheral nerve block is 1.5% mepivacaine with epinephrine due to its fast onset, moderate duration, and relatively good side effect profile. The equipment that you will need to perform both a lumbar plexus block and a sciatic nerve block is listed here. It is important to remember your own proper personal protective equipment, including a face mask, eye protection, gown, and gloves. You will also need antiseptic solution, a marking pen, 4 20 milliliter syringes with your desired local anesthetic. For the lumbar plexus block, 30 to 40 milliliters is usually sufficient, and for the sciatic nerve block, 20 to 30 milliliters is usually sufficient. And you will need some needles. It is important to understand that these techniques are based entirely on anatomy, as it is unlikely that you will have an ultrasound machine or a nerve stimulator when you are required to perform these procedures in the field. I will now show a clip demonstrating the techniques of both a lumbar plexus block and a sciatic nerve block. Before beginning, it is important to ensure your own safety. Make sure you have the proper personal protective equipment. This includes eye protection, face mask, gown, and gloves. To achieve anesthesia of the complete lower extremity, 2 nerve blocks are required: the lumbar plexus block and the sciatic nerve block. To perform the lumbar plexus block, place the patient in the lateral decubitus position with the operative side up. Light premedication at this point is beneficial for patient comfort. For example, midazolam 1 mg IV or 5 mg IM, and fentanyl 50 micrograms IV or IM. Prepare your desired local anesthetic. For example, here I will use 1.5% mepivacaine with epinephrine. 30 to 40 milliliters of anesthetic is usually sufficient to block the lumbar plexus in most adults, and 20 to 30 milliliters is required for the sciatic nerve. Next, draw a line from the top of the posterior iliac crest down to the midline. In most adults, this line is located over the top of the L4 transverse process. Next, draw a line superiorly from the posterior superior iliac spine, parallel to the midline. In most adults, this line is located 5 centimeters lateral to the midline. The intersection of these 2 lines is the point of needle insertion. Generously clean the insertion site with antiseptic solution. Insert the needle with a slight medial angulation to the sagittal plane of the patient at the intersection of the 2 lines drawn. Make small adjustments of the head of the needle, cephalad and caudal, until bone is contacted. This is the L4 transverse process. It is important to contact bone before entering into the plexus, as this serves as a safety landmark of needle depth and prevents insertion too deep into the retroperitoneum. Once bone is contacted, redirect the needle caudally and walk off the transverse process. In most adults, the plexus is located at a depth of no more than 2 centimeters beyond the transverse process. After gentle aspiration of the needle, to ensure it is not within a vessel, inject the local anesthetic. Monitor for anesthesia of the anterior leg in the L1 to L4 dermatome. To perform the sciatic nerve block, keep the patient in the lateral decubitus position with the operative side up and the leg flexed at the knee. First, draw a line from the greater trochanter of the femur to the posterior superior iliac spine. Next, draw a line from the greater trochanter to the patient's sacral hiatus. Draw a third line perpendicular to the first line at its midpoint. The intersection of this third line and the second line represents the point of needle insertion. Draw a fourth line along the groove formed by the medial edge of the gluteus maximus muscle and the long head of the biceps femoris muscle. This line represents the course of the sciatic nerve as it travels towards the lower leg. The triangle formed by the second, third, and fourth line further defines the point of needle insertion. Subsequent adjustments of the needle should be within this triangle. Thoroughly clean the insertion site with antiseptic solution. Insert the needle at the determined point, perpendicular to all planes. The sciatic nerve is usually found at a depth of 6 to 7 centimeters. After gentle aspiration of the needle, to ensure that you are not within a blood vessel, inject the local anesthetic. Monitor for effects of anesthesia on the posterior leg in the L4 to S3 dermatomes.